Is there anyone have a headphone and need to translate back from Vietnamese to English? Please rise up. If no one, I can miss this session. Okay, thank you. The patient have discomfort in the niche area, so we need to have a treatment. Sometimes we need to do the thorough toxicity nodule, like what we have seen on ultrasound. We can see this patient on ultrasound. We can see the lesion, but clinically, patient have a hyperthyroidism. On the nuclear medicine, we can see this is the thyrotoxicity nodule. If we do average of the nodules after 18 months, the nodules disappear. This is also the indication for IFA of the thyroid. So IFA is the solution for patients have a multiple surgery and have the risk of complication after post surgery. Therefore, we need to do the IFA other than surgery. So what we should do before doing IFA? We must be sure this the benign lesions, and at least we need 2 FNA and 1 CNB to be sure it's benign. And then we have to do some clinical evaluation. So we have 4 levels. So grade 1 is we cannot touch, no palpable. The second we cannot see, but we can the lesions palpable. The third we can see the enlargement of the thyroid when swallowing, and the fourth one we can see the mass easily on ultrasound. We can have the benign characteristics on ultrasound, and we can evaluate the texture of the thyroid on ultrasound. That's the decisions. Use IFA alone, or we need to combine with the alcoholic injection. We have to measure the volume of the nodule. And with these measurements, we can have the follow-up after procedure. Clinically, we can give the 4 degree. This is the illustration. We can see we have A, B, and C. 3 dimensions measurement, and to know the volume to compare with the post-procedure size. This is grade 0. We cannot see the hypervascular, and then grade 1, no, grade 2 a little bit, and grade 4 have a hypervascularity. In this case, we can have a prognosis of the lesion after IFA. We have to have some lab tests. We have the blood count. We have the thyroid function. Calcitonin, and also other lab tests to make sure the thyroid function. In some cases, have an abnormality. We have to treatment to give the treatment before doing IFA. So after we are sure the patient have an indication like a benign characteristic. We have the volume. We have a clinical symptom and a laboratory test, CT or MRI. And then patient must be fast 6 hours before doing a procedure. In some clinical practice, we do not need the reality because we just do the local anesthesia, so we don't need to be fast 6 hours. We need to have the venous catheter. So the techniques of IFA, local anesthesia. This the photo. You can see the under ultrasound. We use a 1% lidocaine, 8 to 10 mil, and then we inject to the parathyroidal space. We can see this the needle on ultrasound, and then we dissect the thyroids from the adjacent structure. So the technique, we have 3 principles. The first, we go through the isthmus, and second, second principle is moving in short technique. It's quite different to the liver tumor IFAs, and every activity of the procedures are under control by ultrasound. So you can see here, from the isthmus, we can control the direction of the needle to the nodule. Some explanation. From this approach, we can see the relation between the nodule and the isthmus. We can see the anatomy of the adjacent structure. We can see the dangerous triangle. It's quite difficult to see the retrospective vagus. Actually, when we know the dangerous triangle, we can easy to avoid the complication. Another thing is to avoid seeding. When we do some lesion, the liquid may go retrospectively to the tract and may damage the normal tissues. During the procedure, we can contact and we can talk to patient, and then we can see how patients feel when we do procedure. The second principle is a moving short technique. We ablate different point from medial to lateral, from deep to profound. So in this case, we can control to avoid the vagus, retrovagus nerve. So the difference between the moving technique and the fixed needle. For the fixed needles ablation, we just apply for some other cancer like the liver cancer. So from there, we put the needle in and just burn it. But for the thyroid, because around the thyroid there are a lot of other structure. If we keep the needles still and burn, and then the lesions, the burning size will expand and expand, and may damage the adjacent structure. Therefore, we have to move the needle when we do burning. So in this case, we burn just one by one in a very small spot. So in the dangerous area, we just burn very quickly, and then we have a very small spot in the central of the lesion we can have a larger spot. So with the principle unit by unit, and then we pull the needle and then burn, pull and burn, and give the areas of burning like a fan shape. This is unit one unit, line by line, we can have a fan shape. So here is the nodule just after iBase. It look like the fan. So we have to control all the procedure under ultrasound, particularly using the color Doppler. So before doing a procedure, we have to evaluate the adjacent structure with the color Doppler to make sure that we cannot hit the vessel. When we do apply the compression, maybe the vessel will be compressed. It's quite difficult to see on 2D ultrasound, so we need to use the color Doppler. And then after doing IFA, we can see whether we already burned the tissue, because at that time the air bubble may make us difficult to see the vessel. On ultrasound, we have to find and beware some sort of dangerous structure like the sympathetic nerve. So we have to avoid during the IFA procedure. We have to see where and what we have burned. Never let the needle go through the thyroid capsule. During the procedure, we have to follow up some sort of life symptom like hypertension, pulse, and we have to define the complications, particularly the voice of the patient. In case a patient have too much pain, we have to reduce the IFA's frequency, and actually we don't need to use too much anesthesia, because we can let the patient feel the pain and let us know to avoid the complication. For hemorrhage and hematoma, it's easy to detect by ultrasound. It's not too hard to control. We just stop the procedures and apply the compression. Normally the hematoma will be resolved after 2 weeks. This is the video to see how the procedures can be done. This is the needle go through the isthmus, and then we shot from most inner and most and deepest, and we move backward, and then we apply multiple different spots, and we must be sure that we avoid the dangerous triangle. This is the basic principle for doing IFA. And then finally we cover every single spot of the nodule. So before treatment, the lesion must be hyperechoed, and after that, after IFA, we can see the nodule is inhomogeneous and sometimes it's quite similar to the cancer, and a lot of patients, a lot of doctors maybe see that mimic to cancer. So clinical following up, there are a lot of clinical research. For the short term, 6 or a little bit later, so we need to know that about average about 50% reduce of the volume, and then after 3 months 74% reduction, and 6 months we have almost 85% reduction of the thyroid nodule. Another research 4-year following up, about 100 patients, we see the size of nodules gradually reduce and almost disappear in about 4 years. In some lesions have a mix between solids and cystic. If the patient, if the lesions are almost cystic, they just aspirate and inject alcohol. In some patient have a partly cystic, partly solid, we can aspirate and then inject, and then after that we do IFA. In solid lesion we do ablation. We have a 3 type of lesion: cystic, mixed, and solid. And when you do the good indication and procedure, the lesion will be reduced gradually and normally significantly different after several months. Some other report we can see almost a patient have the lesion reduced in size after several months. So what's going on after IFA, particularly complication? For a study doing almost 1,500 patients, the change in the voice due to the damage of the retrospective vagus is very rare. Actually, it's about 1%. For the experienced experts, so we have a very low rates of complication. There's some clinical case. Females was born in 1971. You can see very large lump in the right neck. The volume about 15 milliliters and cosmetic grade about grade 4. So this is IFA image. Just after IFA, you can see the low echogenicity area. So the lesion was reserved for the triangle, the dangerous triangle. This is after 1 month and 4 months. The lump is almost disappear. And these the cystic lesions, the volume about 45 mil. And this is a puncture, aspiration, and alcoholic injection, and then IFA. After 3 months, you can see 71% reductions in volume. Another patient. This Vietnamese living in Australia. Patient have hypothyroidism and thyrotoxicosis. So we treated with IFA, and just 1 month, patient stopped the medication, and 3 months IFA, you can see everything go back to normal. That is the classical experience. Now is my own experience. We have started using IFA since 2010 of the liver cancer, about 300 cases. We can have some experience in TACI, in portal vent embolization. Here in this case, this is a portal vein angiography and then embolization before doing IFJ to avoid heat sink. And this multiple needle to ablate the last liver tumor. This is the first case working with Dr. Na. This is the first guy in 2014, and we now about 5 to 10 cases a week. And for my experience, I think the average of the liver tumor is much more challenging than the thyroid. So in conclusion, average of the thyroid is one of the choice to treat the benign thyroid nodules, and also we can do in the toxicosis of the thyroid, and also the repeat and the recurrence of the thyroid nodule. Three basic principles. So it's merged approach, moving short technique, and all under ultrasound control.